Welcome to The Healthy CEO, the show where we dive deep into the science of longevity, the art of health span, and the strategies that help high-impact leaders live and perform at their best. I'm your host, Jason Wright. Each week, I sit down with world-class physicians, wellness innovators, researchers, and entrepreneurs who are reshaping what's possible in human health. From breakthroughs in cellular optimization to metabolic health to the habits and mindsets that drive extraordinary performance. This is your front row seat to the future of well-being. Today's episode is brought to you by Authentic Health, where we believe your body deserves more than minimum viable nutrition. Our foundational supplement stack, developed by Dr. Gus Vickery, a physician with more than 30 years experience, is designed to support cellular energy, metabolic efficiency, and total body resilience. If you're ready to take a smarter, more personalized approach to your health, visit shopauthentichealth.com and explore the tools that can help you build a stronger, longer lasting you. Now, let's jump into today's conversation. And remember, you don't just need more years in your life, you need more life in your years. This is The Healthy CEO. Thanks for listening. Hey there, folks. Welcome to The Healthy CEO. Today's episode just might save your life. Here is why. So I am talking to Dr. John Osborne today. He is one of the leading experts on preventive cardio care. So did you know that most people's very first interaction with heart disease is through the form of a heart attack? And here's what's even scarier. 50% end up dying from it. So this is pretty serious business. And here's the cool thing. We have so many ways, like so many other areas of medicine, there is so much innovation being done in the area of prevention that it's really just a remarkable time for medicine. And Dr. John Osborne is at the forefront of this in one of the single most, if not the most critical area as it relates to preventive medicine, which is cardiovascular health. So I'm starting this out right away with the intro because we had a little bit of trouble with the audio whenever we first started. So it's just about 10 minutes of it, of him giving the introduction of how he ended up in preventive cardio care. And then we get really into the meat and potatoes of the interview. So you don't miss a lot, but I thought I would just come on right away, give you the intro, and then we'll start the show like we normally would. So who is Dr. John Osborne? Well, he's a brilliant physician. Dr. John Osborne is a highly distinguished cardiologist and the founding director of State of the Heart Cardiology. He earned his BS with honors from Penn State University, an MD magna cum laude from Jefferson Medical College, and a PhD in cardiovascular physiology from Thomas Jefferson University. Dr. Osborne's postdoctoral work at Harvard Medical School and Brigham and Women's Hospital laid the groundwork for his expertise in non-invasive cardiology. Uniquely board certified across multiple disciplines, including cardiology, internal medicine, lipidology, clinical hypertension, cardiac CT angiography, echocardiography, and nuclear cardiology. His clinical focus embraces preventive cardiology, metabolic syndrome, and cardiovascular genetics. Dr. Osborne has been honored with numerous awards, such as the American Heart Association's Cardiac Care Provider of the Year, and has been recognized as a top doctor multiple times. His contributions to medical literature are extensive, including original research papers, book chapters, and hundreds of international presentations. Looking ahead, Dr. Osborne aims to advance the field of cardiology through ongoing research in vascular biology and genetic factors affecting heart disease. He is committed to improving patient outcomes through innovative, non-invasive treatments and continuing to influence the next generation of cardiologists through his roles in national committees and educational initiatives. He is also the founder of Clear Cardio, an initiative dedicated to enhancing proactive cardiac care and patient empowerment through the introduction of AI technology for disease detection and treatment. This guy is amazing. And in fact, what Dr. Osborne keeps saying is that he is on a mission to put himself out of business because he wants to reduce heart disease down to zero. He's a moonshot kind of guy. He talks about in this conversation about how he wants to completely eliminate cardiovascular disease. For so long, our healthcare system has been diagnose, prescribe. You go to the doctor after you're sick, but I think we're finally moving into a more proactive way of thinking with regard to our health. And what's more important than tackling preventive care as it relates to cardiovascular health? That's exactly what Dr. John Osborne is doing. It's an awesome conversation. I hope you enjoy it. And hey, if you do, or if you have a family member that they just aren't really paying attention to their heart health, they should, but they're not really doing these things, or maybe they want to go over to Carrollton. He's right here in Texas, at Carrollton, Texas. You want to go find out more and you want to reach out to them, share this episode with them. I think it's going to offer you a lot of eye-opening insight to cardiovascular health that I think we could all benefit from. And also, if you enjoy it, please, if you're watching this on the YouTube channel, go ahead and click subscribe, click like, and share this there. Leave some comments. If you're listening to this on Spotify or Apple Podcasts and you like the conversation, please consider leaving a 5-star rating. That really helps us out. Here is my conversation with Dr. John Osborne. Thank you for listening. Hope you enjoy it. So when it comes to detecting plaque and potential cardiovascular disease, we are in a better position now to take proactive measures to prevent a cardiac event that could lead to heart attack, heart failure, whatever. And we're in a better position. So I'm just going to start at the most rudimentary place in this whole thing. I know I just turned 50. Well, I say I just turned. I'm about to turn 51 early next year. But I got my first colonoscopy at 50. And I know a lot of people are saying, but if you've got good insurance, or even if you're going to pay out of pocket, I think it's like a couple grand, you can go get a colonoscopy and you can be preventive. And as long as you check that, I think you mentioned this, as long as you're, going to being proactive, you can fix the problem before it becomes a real issue. With regard to understanding heart disease and where you are, how early should you start to look for some of these things to be proactive? And to kind of give a second part of that question, what things do you look at? Because what we always hear is you see people that are healthy or seemingly healthy, they drop dead of heart attack. Well, it's because they had all this stress and all these things going on internally that we didn't know. Sounds like this could help, catch some of that stuff early. So what are some of the either early indicators, just being proactive? What age do you suggest people start really proactively going to see what's under the hood or in the veins, however you want to, qualify that, to figure out what's going on?
No, brilliant question, Jason. And I think to some degree, you sort of answered that by yourself. So just like we do colonoscopy, in fact, we just moved in the last couple of years from 50 to start screening colonoscopy to 45.
Yep.
Right. Because we're finding cancers in younger people. So for heart disease, and I'll tell you some interesting statistics in a moment that kind of reinforce this point. We're going to say 40.
Okay.
Because the heart disease that begins to kick in our 50s, 60s, right? It's already there by your 40s.
Wow.
In most all people. So we can see it, detect it, which gives us ample time to correct it, right? Detect it, correct it. If you wait too long, we may find it when you already have severe disease, advanced disease. I'll call it analogous to stage 4 cancer, advanced metastatic cancer. And by that point, the solutions may be not just medical, right, to stop plaque and reverse plaque, but you may need mechanical therapies, balloons and stents and bypass surgery. So our goal, and please don't tell my interventional colleagues that do the stents or my cardiothoracic colleagues that do bypass surgery, my goal, and I tell them this all the time, they sort of laugh at me. Now they're laughing less. My goal is to put them out of business, right? That we do a great job of early detection and coupled with prevention, that those mechanical approaches are irrelevant.
Yeah.
Right. I think it's a little bit like dentistry, right? Back when I was a kid, right? 60s, 70s, right? Cavities, like, let's get rid of cavities. And to be honest, the dentists have done a fantastic job with all the tools and sealants and all those things of getting rid of cavities. Yeah. God bless them. Yeah. Right. Now they're okay. Right. And they move from that to cosmetics and all those other specialties they have as we get older. Right. So I think that really is the path we should be taking in cardiology. Right. I think there are 33,000 cardiologists in the US right now. there are about 600 preventative cardiologists. And I think those numbers need to be absolutely reversed.
So it's interesting. So, I wrapped a podcast right before coming on here, and it's so encouraging because the guest I just had on, he's in more of a tech-based company, longevity company that he's involved with. But there's so much more attention on this topic, doctor, with regard to prevention, and the costs are getting such that you can actually, like you mentioned, we're getting this where we can do it at scale, and it's not just for those who have the money to go do all the prevention in the world. And I think that is a very encouraging thing. Now, for those listeners out there right now who are in their 40s, which that's interesting you say it, because usually correct me if I'm wrong, isn't the number something to the effect that most people don't know they have heart disease until they have a heart attack, of which about 50% of them drop dead at that point? Do I have those numbers?
Absolutely correct.
Yeah.
Yeah. So about half the men, 2/3 women, the first symptom that you have of heart disease, I got a problem, is when it kills you.
Wow. So,
Right.
So that should encourage people to go get this checked out.
Yes. And here's some other stats, right? So we talked about, you mentioned colonoscopy, which I think is a beautiful analogy to what we're doing, right? And we do colonoscopy at the screening level. Everybody gets it, right? And we pass laws in the ACA to try to reduce costs and barriers and all that stuff. And I absolutely 100% agree. In fact, I love telling my patients, when I talk to them about colonoscopies, I say, make sure you get your colonoscopy, because I'm not here to save your life from heart disease for you to die of colon cancer. That's not allowed either, right? So here's the numbers, though. 2 to 3% of us, statistically, will die of colon cancer, which is 2 to 3% too high.
Yeah.
45% of us die of plaque, of atherosclerosis, of cardiovascular disease.
Mm-hmm.
So what do we do to identify the 2 to 3%? We do colonoscopies. Everybody gets it. It's a painful, kind of uncomfortable thing, a day of your life. You get general anesthesia. The prep, of course, is the worst part. The anesthesia actually pretty nice.
Exactly.
But that's going to take a day of your life. 0.1% chance they perforate your colon, which is never good.
Yep.
But we should, right? Find the polyp, take care of the polyp. Or the flip side, and the same thing is true with heart disease, is not only find early disease, but just there's no plaque.
Yeah.
I'm fine.
Yeah.
Right? Everybody in my family has heart disease. I mean, I know a couple of years ago, an amazing particular case always sticks in my mind. Woman was 58. Her dad died in her arms in her 20s of a heart attack, right? And pretty much most of her days, ever since that happened, is today going to mean by day? Now, she'd been through EKGs and stress tests and all those. They were all fine, but she'd never heard of what we did. We got her in. In fact, it was actually her husband that we brought in, and he had quite significant heart disease. No symptoms, works out 4 or 5 times a week. Ripped. They both, ate perfectly, no blood pressure, no cholesterol, no diabetes. But he chose the wrong ancestors, and she was worried that she did choose the wrong ancestors, as I like to say, right? So we scanned him. He had extensive plaque, but we were able to take care of it before he needed stents and balloons and surgery, which is beautiful. So everybody's happy. But we put her in the machine because of her family history and her dad, and she had no plaque, had nothing at all. Right. So all of her efforts on diet, exercise, lifestyle, and she didn't get whatever genetic thing dad had, she had no plaque. So she literally cried for the first time in 30 years. She knew she was going to be okay.
Yeah.
So it really does work both ways, but it's amazing to think 2 to 3% of us die of colon cancer. We go through the colonoscopy thing, and we should 100%. But 45% of us die of cardiovascular disease, strokes, and heart attacks. And what have we done to detect the disease early? Nothing.
Right. How does the insurance treat the scans that you're doing?
So here's the challenge. I think this will change and evolve. If you have symptoms, if you have chest pain, angina, maybe shortness of breath is what we call an anginal equivalent, some symptom that might suggest that you have a blockage, they'll pay for cardiac CT, which is great.
Mm-hmm.
But that only applies to the symptomatic people. And as you mentioned, and I said yes, half of people, the first symptom of heart disease, roughly, is you die.
Yeah.
So that's not going to benefit half of the men and 2/3 of women because their first symptom is they die. Then we take the people with symptoms, and by that point, they probably have really quite advanced severe disease. Again, I'll use the cancer analogy, they already have stage 4 disease,
Yeah.
advanced metastatic disease, right? As far as heart disease goes. And by that point, by the time you're having symptoms, yeah, you probably need stents and balloons and surgery because that plaque has been growing there without symptoms. I feel fine, normal stress test, literally for decades. And only until it gets quite severe, you have generally at least 70% blockages or more in one or more blood vessels. Then we start having symptoms or flunk a stress test. But that's only in the lucky people. The unlucky people, the first symptom of the disease is you die.
Wow.
So the challenge is insurance companies right now do not see this as a screening test like we do colonoscopy. It's only for people who have symptoms.
Well, well, Dr. Osborne, I actually have an office in DC. I'm the president, in addition to other things I do in the private sector, the president of the Access to Health Foundation. And we need to talk about that. I mean, because I think CMS, HHS, they need to know these. We need to have these conversations more often because another statistic, if I'm not mistaken, cardiovascular disease is still the #1 cause of death in the U.S.
Oh, by far.
Right.
Even during COVID, right? We're losing 1 million people, right? During COVID. It still remained the leading cause of death. In fact, it's been the leading cause of death for about 120 years in the U.S.
Yeah. And as we talk about value-based care, which is to incentivize physicians to keep people healthy versus just the fee-for-service, they come in and how many people can we see, check the box to whatever you're trying to, whatever United Healthcare says, whatever the ACA, markers are, and get them out and see how many, but no consideration given for, okay, that patient that you just saw and that you diagnosed and prescribed, did the prescription work? Did they get healthier?
Right.
It's
right.
So that's what's lent to this care system versus healthcare.
It's matrix medicine. It's MBA medicine.
100%.
Right?
Yep.
And I've never subscribed to that.
Yeah. Well, and it's so refreshing to hear. I mean, you're right in to me, it's funny, Doc, whenever I'm in DC and you talk to members of Congress about value-based care, it's one of those things like they all know it's good. Well, yeah, absolutely love it. But they don't know what the hell to do. They don't know what it is, and they don't know how to make it work. This, to me, is some low-hanging fruit, is getting more people doing the CT scanning, figuring out where they are. And also a conversation that we all have a lot around this is how do you change the behavior of the individual to get them to have a big enough why to actually do the thing you're trying to get them to do? Well, to me, if you went and you had a verifiable issue with your cardiovascular system, that's going to be a pretty big, mover to get you to change some behaviors, right?
Right. Well, and it's amazing too, when you think about cost, right?
Mm-hmm.
So, colonoscopy, not inexpensive.
Yeah.
We talked about that, right? Invasive, et cetera. If you go back to cardiology, right? The typical conveyor belt in cardiology is you go to a cardiologist because somebody's worried about you. Maybe you have family history or your risk, or maybe you got symptoms, right? We're trying to sort it out. So you get your EKG, you do a stress test. You might do a couple stress tests, maybe a regular stress test and then a nuclear stress test, right? We do 10 million nuclear stress tests a year in the US, 10 million.
Wow.
And these are about $5,000. This is MSRP, right? You may not pay $5,000, but somebody's going to be billed about $5,000 for that. And the radiation dose is a lot. Okay.
Mm-hmm.
And then if your stress test is positive, then you go on for a $20,000 invasive heart cath, which, by the way, can only see the channel, can only see the lumen. You can't see what's happening in the wall, in the donut, as I like to say, right? So you could have a perfectly normal angiogram, and we see it all the time, and yet have significant plaque that we can only see with cardiac CT. That's $20,000 and invasive, and hopefully they didn't damage your kidneys. You don't run into a vascular maladventure, therapeutic maladventure. You didn't cause an infection. You didn't have a stroke or heart attack, and it's still $20,000. So the costs of what we are doing right now, and we do 2.5 million of those every year in the US, right? I stopped doing them 20 years ago because cardiac CT was 1/10 of the cost, gave me better data, cheaper, faster, simpler, easier, less radiation, less contrast, all of those things. And rarely in medicine you go, well, we save money, but, right? Or it's better, but it costs, right?
Right.
I mean, and it's one of those incredibly rare things in medicine where, yeah, it's better across the board. It's cheaper, faster, better, more accurate. more sensitive, less risk of complications, less radiation, less contrast, all the things that we in cardiology, worry about. Well, we did that 20 years ago. And of course, it's only gotten better and better with the hardware and software available. And now, as I said before, the big advance is the AI. The other thing, let me tell you a fascinating statistic. Using AI, which I call the microscope, right? Now we have an incredible tool that can see what we could never see before. In fact, literally with what we could do today with cardiac CT, now coupled with AI, the only way that we could come up with that data in a person was to do an autopsy.
Wow.
Right?
Yeah.
Now we do the virtual autopsy. My staff always says, stop using that term, but it really is very accurate. It is the virtual autopsy,
Yeah.
right? Now using AI, here's something that's shocking, okay? Heart disease, plaque, is unbelievably prevalent. Using the microscope of AI, 1% of us will have no detectable plaque.
Really?
1%.
Wow. Wow.
So most all of us have plaque.
It's
Now,
smart.
because we can also quantify plaque very accurately, we now have stages, just like cancer.
Mhm.
So 0 would be 0. Stage 1 is mild. Stage 2 is moderate. And stage 3 is severe. And this is based on, and I hate to get too technical, but how many cubic millimeters of plaque you have in all of your blood vessels of the heart, which we can now both see and detect and quantify very accurately. So on one extreme, 0, no plaque whatsoever, is only 1% of us. It's like getting a perfect score on the SAT. It does happen, but not often, okay? On the other extreme, stage 3, which for the record means above 750 cubic millimeters of plaque, which is a lot, okay? That's stage 3, which, by the way, in the next 10 years, if you're stage 3, if it's not detected, taken care of, and treated, you have a 40% risk of a heart attack. So almost half, 50-50. A third of our patients getting in our machine to do cardiac CT and AI the first time, right? No symptoms. I feel fine. I like to say normal stress test last week. We can talk about how poor stress tests are, by the way. A third of our patients getting the machine first time will actually have stage 3 disease.
Really?
No idea, no symptoms, normal stress test.
Wow. Wow.
Yeah.
That's great. Okay. All right. So I guess one of the things that I would like to know is, all right, let's talk about some either indicators or causation of
Sure.
the heart disease. And because some people, we're just not going to get them to start being as proactive on this. So would you say, like, what are the major factors that are going to cause, and I want to stick with plaque buildup because I've never really talked about plaque on the show. I usually
Yeah.
talk only about,
As it turns out, heart disease,
Mhm.
now you can develop valvular heart disease and heart rhythm issues. I mean, there are other parts of cardiology, but most of it is plumbing, right?
Yep.
And my joke is when people ask what I do, I like to say I'm a general contractor or do some plumbing, I do some electrical. So there's all kinds of electricals. We're not going to talk about that. We're
Right.
just talking about plumbing today. But when you talk about that, it's really plaque.
Okay.
Do you have plaque? How much plaque? Where is it located? If your cardiologist can't tell you that, they're not doing the right kind of testing,
Okay.
right? So stress testing, by the way, right? So you go to cardiologist, they do an EKG, they do a stress test. Here's the problem with stress testing. Now, admittedly, I was board certified for 20 years in nuclear cardiology. That's the people who do the nuclear stress tests. I stopped doing those because they expire after, 10 years. I did 2 rounds of it. I don't do it anymore because they're a worthless test. But we do 10 million of those a year in the US, okay? So the value of stress testing in 2025, it's great if you lack a Lamborghini, a Ferrari, a Cessna, a lake house, a boat.
Yeah.
Okay.
Yep.
Stress tests are great for that.
Yeah.
As a diagnostic tool, they're really terrible. So any blockage, and I'll tell you why, any blockage less than 70%, your stress test will be normal.
Okay, I got to ask you though, real quick, doctor. I got to ask you. I got to because I'm just going to step out on a limb and hope it doesn't snap. But I got to believe there's another cardiologist that's going to take issue with that. What is the controversy
Sure.
there? What would their argument be to steelman that argument?
We've known this. We'd started doing nuclear stress testing back in the early 70s, right? We've known. Now, when you only had stress testing, we had the cath lab and stress testing. Well, we can't cath everybody
Right.
before we had cardiac CT. So stress testing was the tool you had.
Okay.
Now that we have cardiac CT available, it's a 20th century tool,
Yeah.
right?
Yeah.
So, and the data I'm citing is absolutely 100% known, right? These are not debatable points within the stress test world or nuclear cardiology. So any blockage less than 70%, your stress test will be normal, right? Because it only can detect what we call flow limiting blockages, which starts at about a 70% level. Furthermore, because we're not imaging the blood vessels themselves, we're looking at blood flow, we have about a 25 to 40% false negative rate that there is a severe blockage and the stress test looks fine,
Yeah.
which you can imagine is not good at all.
Right.
Because then we're patting you on the back saying you have the heart of an 18-year-old and then stuff happens. And then we have a 25 to 40% false positive rate where the stress test looks funky. And then we go on to a $20,000 heart cath, only to find out you look great. I don't see any blockages. Maybe some lumpy bumpy,
Mhm.
right?
Mhm.
But no blockages. We don't need stents or balloons. And in fact, if you look at the cath lab data, roughly 70% of the people going to the cath lab, we find do not have blockages or are normal. They don't need stents or balloons. So you can tell we're not using very good gatekeeping tools to figure out who should undergo an invasive $20,000 test. Now, if you have blockages and need stents or balloons or surgery, yahoo, but 70% of a $20,000 test that we do 2.5 million times a year, that's a big chunk of change.
So that leads me, and again, I told you I do a lot of work in Washington, D.C. Is it because, and I hate going that route because I don't say it's nefarious, but I mean, is it, but just because that they have a big
Habit.
lobby? Is that what's going on? Is it
Yeah.
financial?
Yeah, they do. They do. In fact, one of the biggest medical lobbies
Mhm.
is the AHA.
Mhm.
And this is not who you think of, not the American Heart Association. It's the American Hospital
Mhm.
Association.
Mhm.
Okay. Now I know my tires are probably going to get slashed. Okay. They're in the medical industrial cardiology complex and $5,000 stress tests. Yahoo. With a high rate of false positives, right? Well, whether it's false positives or negatives, they don't care because that generates then another $20,000 for a diagnostic cath that can't even detect and can't even say, yes, you absolutely have no plaque. Because you can't do that. Because all I can see is the channel, the lumen, right? You could have lots of plaque in the wall of the vessel. Part of it is organizational and institutional apathy and inertia, right? Now, I will tell you, when I trained in the 90s, we did stress tests and echocardiograms, which we won't talk about today, which are a great test. And we did heart caths. Those are the three big tests, right? Echocardiography, great test to look at the heart function, the squeeze for valve disease. Tells you nothing about the blood vessel of the heart, by the way. But we knew that nuclear stress testing, now we have what's called PET stress testing, which is also a form of nuclear stress
Mhm.
testing. A little bit better, a little more accurate, but only marginally. These are 20th century tools.
Yeah.
And again, I was able to stop cathing people doing invasive angiograms 20 years ago, never look back, right?
You know, this is what pisses me off, Doc. Is like, so I was on a call with one of our senators, staffers that's on the health committee just last week. And, you know, right now the big argument is the subsidies, the subsidy extensions for ACA. You know, it
Oh,
always
yeah.
gets caught up in the payment, the payment. Are we going to pay? Are we? But there's not enough conversations that I can see happening at this level where it's like, okay, instead of arguing about how much money we need to throw at the problem, why don't we start trying to figure out more innovative ways to take waste out of the system? This seems like a great start.
Oh, yeah. I mean, in reality, what you're really saying to me, you go to the Capitol, you talk to the senators, and you get quickly into this discussion about the cost of vacuum tubes.
Yeah. Yeah. You're right.
Well, vacuum tube prices need to come down. We need more vacuum tubes. No, no. You need to come into the 21st century.
Yeah, and there's so much medicine like that. It blows the more that I've gotten into this, especially from the policy side, um,
Yeah.
and also just my basic, I love longevity and health and wellness and understanding, every aspect of the health space. It's really crazy. I think a lot of people are naive to just how archaic some of the things we're doing
Oh,
are
I'm telling
today.
you. Yeah. I mean,
I
again, if you go to the cardiologist, they start with an EKG, a stress test, and say, maybe we might have to cath you. It, it started out with sort of annoying years and years ago, but now in 2025, 25 years into the new millennium,
Yeah.
and I've been doing cardiac CT for 25 years, right? Now, when I see that, it's beginning to become almost infuriating.
Yeah.
Right. That that everybody should have exposure to this, that this shouldn't be, oh yeah, well, we don't do that, or I don't know, or I didn't study it, or when I was in my training, blah, blah, blah. When I came out of my training, cardiac CT did not exist. It wasn't even a glimmer in someone's eye. So I had to retrain. I did on-the-job training because I'm going, hey, this is incredible. This is an incredible advance. It's going to take some tweaking. We need to work with it for a bit, but I could see where this was going to go.
Yeah.
Right. And it did. But a lot of my colleagues go, well, I don't know. They taught me how to do stress tests, heart casts. That's kind of what I do. I still get paid to do them. And as long as you get paid to do them, well, what's the impetus to change behavior, frankly? So there's a lot of that, unfortunately.
And so I
think it's going to be the patients demanding this, because there'll be a few cardiologists out there go, oh, wait, this is a great thing. I'm going to change what I used to do historically because this is just a better, safer, more accurate, cheaper test.
Right.
So there are those that have done that, but that's unfortunately a very small minority. And I don't want to get too much in trouble with my other cardiology colleagues, but that's just the truth.
I get it. And that's one of the things too, that, when you talk about value-based care, everybody's trying to solve for value-based care. How do we focus more on outcomes? How do we incentivize physicians to keep patients healthier versus everything right now that drives the economic engine in American healthcare is people being sick and taking drugs and just doing this by making sure you don't get sick doesn't really do much for the current state of affairs.
I love telling my patients my ultimate goal, eliminate heart disease.
Yeah.
But along the way, at your level, the patient level, what I want to do is I want to make your life medically boring.
Yeah. Yeah.
There's no catastrophes. There's no heart attacks, strokes. There's, because these things have their genesis in things that started decades earlier.
Yep.
And the technology exists to find them. And talking about longevity, right? I just gave a talk several weeks ago at a really phenomenal, this is great, I'll put a plug in, called the DOC Symposium out in Napa. A guy named Jordan Slane, who's brilliant. He's concierge doc, put it together with another guy who's a really big thinker, John Battelle.
Yeah.
Phenomenal.
John Battelle.
It's great.
Yeah.
Yeah. And it's definitely worth going. So I talked to them, or gave a talk about cardiac CT and prevention and really changing up this whole paradigm. And my point was, now this is mainly a longevity symposium, right? My point was 45% of the deaths right now are due to something detectable, predictable, and preventable.
That's great.
And if you do not have lifespan, forget about health span. It's no longer relevant if you die on the golf course at 50 of undetected heart disease, right? No matter how much NAD you take and Sermorelin and, testosterone or whatever, is big in the longevity world, right?
Yep.
It doesn't matter if you're dead.
Yeah, right. Yeah. That's great. Well, and I think right there, what you said, I mean, that might be the plug of I'm going to have to make that a reel and a short for the promotion of this podcast, is that 45% of the deaths are freaking detectable and therefore completely, for the most part, unnecessary. And I don't think a lot of people have come to that mindset yet. And I think that, and, Godspeed for what you're doing, because you talk about how you want patients' health to be boring. And so when I went to get my colonoscopy, this was really, it kind of pissed me off, to be honest, that not at the nurse, but just in general of what she's used to seeing. So I go in and, they're doing the check-in where they're asking me about all my medications. Do you take this? Do you take, no. And she said, and literally there's nothing to check on mine. And I take no medications of any kind. I'm 50 years old. And of course my health and wellness is the closest thing I have to a hobby, right? It's really, I'm not that bright of a guy. It's just common sense stuff.
Right.
And she said, well,
that's skin in the game.
That's it. And she goes, eventually she said, well, do you ever go to the doctor? I said, absolutely. I go once a year. for my wellness visit. Now, if it was, during COVID, I had to go because I was diagnosed with COVID. So I went to the urgent care, got fixed up. And by the way, I continued to ride my Peloton straight through COVID because, and maybe not as hard, but that's to me, doc, you can't
Oh,
prescribe me better than
absolutely.
exercise, right?
Oh, yeah.
You know that.
Absolutely. Right. Well, in fact, less COVID, better COVID outcomes in people that were physically fit
Yeah.
and not overweight.
Yeah.
Okay. Whereas I like to say in Texas, none of my patients are overweight. However, many are under height.
Right. 100%.
That's all I'm going down that road. But anyway,
100%. But that's
Right.
the way, to me, it's like I was this anomaly. It was so not, she just couldn't believe it. And I mean, and she thought the reason I didn't take any prescriptions is because I just must not go to the doctor. I'm like, no,
Right.
if you just do these things and I,
Oh gosh, absolutely.
Right.
Right.
and I don't,
Plan A for everything when I see patients is what we can do with diet, exercise, lifestyle.
yeah,
That's plan A for everything.
yeah,
Now, some things are genetic. We have a discussion about that, right? But absolutely, plan A has nothing to do with meds,
right,
right?
right.
And that's, I want to make everybody look like you.
Well, I appreciate I work at it, but it's fun work. And another thing too that I have that doesn't have anything to do with exercise, but I have, and I want you to talk about this a little bit because when you talk about endothelial health or any of these things,
Mhm.
one of the things that I took for granted was stress and anxiety and its impact on cardiovascular disease. Um,
Mhm.
how do you manage your patients? Like, does that detect, like, how does a CT scan, because does that contribute to plaque buildup? I mean, I guess that's my simple question.
Yeah, I think you asked me before, and I didn't mention it, but okay. So here's the big four
Okay.
that are modifiable.
Okay.
Okay, I'll mention that few that aren't but that are not modifiable.
Okay.
Today we're working on that. Okay, the big four modifiable factors: tobacco use.
Mm.
Okay, when I say tobacco use, I mean I don't care whether you smoke it, snort it, chew it, inject it, rub it on your skin, use it as a colonic. Literally, tobacco nicotine will get into your blood vessels. It'll circulate. It will activate nicotine receptors on your endothelium and turn that vessel from Teflon into Velcro.
Wow.
You do not want sticky vessels. So I don't care how you get exposed to nicotine. It is a bad chemical. Okay.
Wait,
So
real quick, I want to, that's interesting because I had wondered why, because you like Ben Greenfield and a lot of the other, big names in the biohacking world, they will talk about taking the little nicotine pills for cognitive.
yeah, boy, I've heard that. And it really, it doesn't have much to do with what we know about the biology of plaque. Right.
Okay.
It gives you sticky vessels, right? So it's kind of like saying, well, Dr. Osborne, how much cyanide can I safely consume?
Got it.
How about 0?
Yeah.
Probably 0 is the best amount of cyanide,
Yeah. Thanks.
right?
Thanks for
Insert
adding
your
alcohol
poison
at this
here.
point. I mean,
Yeah.
I'm not saying there's anything bad. I know you can do it in moderation and
Yeah.
once.
Right.
I just finally decided I'm out. I don't crave it enough. So
Risk benefit. Yeah. Right. But yeah, some nicotine definitely falls into that,
okay. Okay.
right? It's not just bad for bees, it's bad for us too, by the
Yeah.
way. So there's neonicotinoids and all those. They're insecticides.
Well,
by the
that's
way.
good because I never really researched because I know there was a government deal where they were like really coming down hard on trying, I guess, to ban the nicotine pills or put some sort of
Yeah,
regulation.
patches and
Yeah, and so I never, and then
and
you hear the guys like Andrew Huberman and some of these other guys saying, "Well, I take it for cognitive enhancement." That's good to know. I didn't know that it impacted
again,
endothelial health.
health span, lifespan.
Yeah, yeah. Got
Yeah, again, it's I couldn't. I don't see any good data out there. I mean, that's different. I mean, maybe it helps your brain. People talk about that with nicotine. However, it's a big. It is a major health issue, right? And in fact, if you quit smoking, and I say smoking because most of the day is with smoking, but again, I don't care what how you consume your tobacco. We'll throw vapes in there too. I don't know if I
Ugh.
specifically mentioned,
yes, that's
but if you quit smoking using tobacco in 1 year, forget anything else you do. Diet, exercise, quit drinking, whatever else, right? Whatever good habits, lifestyle you do, or even medications. Just by quitting smoking, you lower your risk of a heart attack or stroke by 50% in 1 year.
wow,
That's a massive bang for the buck.
wow.
And in fact, we know this is interesting, getting back to like the microdosing.
Mm-hmm.
There are people that, like you'll come across them. I smoke 1 cigarette a day or 5 a day,
Mhm.
right? So here's the data. If you smoke one cigarette a day, you get a third of the harm of smoking 20,
Really?
right? For one,
Wow.
right? So I encourage people who choose to smoke. I'm a libertarian, right?
Mhm.
I mean, I'm not dying from it or getting cancer or heart disease from it. So I tell my patients now, please put on the joke sign here, but I tell them if you choose to smoke one cigarette a day, you're getting a third of the harm of smoking 20. You might as well smoke the whole pack. Enjoy the whole pack because you're only magnifying the harm,
Yeah.
you know, from 1/3 to the 100%.
Yeah.
Um, so yeah, so that whole microdosing, at least in the world of tobacco, where we have huge amounts of data, yeah, one cigarette a day is as harmful, is 1/3 of the harm of smoking 20.
I swear, man, whenever I watch those episodes of Mad Men, I don't know how people functioned in the 50s. My grandfather was a chain smoker.
He didn't.
Of course,
Yeah.
my grandfather died at 57 years old of a massive heart attack. So that okay.
Peak peak cardiovascular death was the 1960s.
Makes sense. Makes so much sense. All right. So now we're down. That's number one.
Okay,
No
so
tobacco.
tobacco, high blood pressure.
Okay.
And here's the 411 of this. High blood pressure. New guidelines came out in August. Uh, talk about high blood pressure. The numbers haven't changed for the definition, but here's the important thing. A, the best way to check your blood pressure is at home with your blood pressure cuff. It is more accurate than the blood pressures we get at the office.
Really?
Yeah, because you get a lot more numbers,
Okay.
right? Depending on who took it, their experience, manual, machine. There's a huge amount of variability. You know, how upset or excited you were, you know, if you had coffee earlier, blah, 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 right? So huge, and they'll check it once in one arm.
Okay.
Check it at home. You'll get a lot more numbers, much easier to see what the trend and the average is. So we want your blood pressure to be below 130 over 80. Anything above 130 over 80 consistently is high blood pressure.
Okay.
Normal, however, is below 120 over 80.
Okay.
Okay, that's normal. And we know if you have a blood pressure of 115 over 75, amazing science, I won't get the details, we don't have time, but amazing science shows if you have a blood pressure of 115 over 75, compare that to this person's identical twin that is identical in every way, except his blood pressure is 135 over 85. So in other words, 20 points higher on the top or 10 points higher on the bottom. Identical twins, I like to say, right? So we've isolated just high blood pressure as a risk factor. That identical twin at 135 or 85 has twice the risk of a fatal stroke or heart attack versus its identical twin at 115 over 85. And every time, starting from 115 over 75, every time we go up 20 points higher in the top or 10 points higher in the bottom, that risk of a stroke or heart attack doubles. So at 135 over 85, it's twice as high. At 155 over 95, it's 4 times higher. At 175 over 105, it's 8 times higher, solely based on the difference in blood pressure, not cholesterol, diabetes, weight, smoking, good habits, bad habits, solely based on blood pressure. In fact, if we were able to eradicate high blood pressure tomorrow, which, by the way, we have lots of effective non-pharmacologic tools, diet, exercise. DASH diet lowers blood pressure by about the same as my giving you a pill, by the way, which I always say is my first pill I want to talk about. And we have 150 different drugs to lower blood pressure. So it is a doable thing. If we did that, because half of US adults over the 18, I'm just talking over 18, have high blood pressure, right? 25% between the age of 20 and 40, by the way. And from the age of 40, the lifetime risk of developing high blood pressure in the US is 90%. It is the silent killer because you feel fine
Yeah.
until you don't.
Yeah.
If we were able to eliminate high blood pressure tomorrow, we would tag on. So here's the longevity play. We would tag on to everybody's lifespan, sharing that benefit over everyone, 3.2 years to everybody's life.
Wow. That's amazing.
Which is massive,
Yeah.
right?
It's huge.
And I will say in the longevity space, you know what I never ever hear about?
Mm.
Blood pressure.
Yeah, you're right. I was about to say the same thing. You never hear it talked about. It's almost one of those
No,
like,
you talk about low hanging fruit, right? You mentioned that.
yeah.
Massive low hanging fruit. And I'm going to tell you another statistic, and I don't want anybody to send me nasty emails or whatever, but it's true, right? We get 3.2 years if we were able to eradicate high blood pressure because it's so common and many times poorly diagnosed and poorly treated and only poorly controlled. Of those that are diagnosed, treated, and under control is probably 25% of people with high blood pressure. So we're doing a horrible F job on high blood pressure. If we eliminate it tomorrow, we'd add 3.2 years. You talk about value-based care. Let's start with high blood pressure,
Huge.
right?
Yeah.
3.2 years. Women getting mammograms adds 30 days.
Really? And yet that's all we hear about.
So there's a big disproportionality between benefit
Yeah.
and what we do, frankly.
Interesting.
So,
And again, why? Do you have any theories?
doesn't pay the bills,
Yep, there you go. That's
right?
crazy. And I hate
$50,000 stents, $150,000 bypass surgery, right?
yeah. And
Yeah.
I hate to be that guy.
Identifying, treating, controlling high blood pressure doesn't pay the bills. So, by the way, one of the pieces of paper I have 7 boards, is in hypertension. No one does it because it doesn't pay anything, right? But, I really felt it was part of my training in preventive cardiology to really understand hypertension, mile deep and maybe an inch wide, if you will, but, really deeply understand that.
Now, one of the things that I didn't ask you about earlier when we were and please, we got to get back to our floor.
We'll
When we were talking about the CT scans and using AI with it. So, will the like how much will the AI give you as far as I know it can probably give you what's going on and tell you, hey, here's how we interpret this. So therefore, I'm thinking that a new physician doesn't have to go through everything you went through. I'm thinking that
Oh gosh, no. I mean, I wouldn't recommend on the job training, but now it's I won't say it's dumb. I don't want to use the term dumb down, but it's now so accessible.
yeah.
So we get all the data on one piece of paper, the pictures of the vessels. We can see the plaque. We can see the plaque growing outwards. We get all the numbers, right? How much hard plaque, soft plaque, total amount of plaque. So it is really, any primary care doc could and should be doing this.
There you go.
Right? I mean,
That's what I was
it took me 25 years, but because I'm slow. But it's now evolved to the point where it's very accessible and understandable.
yeah.
Right?
Yeah.
And I literally go through these reports with my patients so that when we get the scan, go through it, I show them the pictures, I fly up down their heart. It's very cool. But I share this with all of them and walk them through the report so that my goal is, they understand exactly what's going on.
Yeah.
Right. And I think we don't have enough time, unfortunately, to educate our patients.
Yeah, well, that's a lot of the problem, and so that's why I get to. I mean, like I'm thinking you went there even before I got there, which was in a primary care setting, which is such a struggle right now in our country. Right?
I really hate to say the term pity, but I really do pity primary care doctors. It's a no-win game.
Yep, 100%. But just in going through these things, if someone walks through my door and I take their blood pressure, which I'm already doing, they probably need to get home. So it's like a weigh-in, so you get a better number. So I'm fully on board with that. But at least they're going to take their blood pressure. The nurse will do that.
Sure.
I tell you,
Sure.
don't freaking smoke. And if I get you a CT scan and I know how to interpret it and tell you what's going on, well, hell, I've made pretty big strides in
Massive.
preventive cardiovascular.
And that's 45% of our mortality you're talking about.
Yeah,
that's a big wedge of that pie chart of mortality.
Right.
It's massive.
Which right now, as it stands, and again, not to be too simplistic about it, and you say, Jason, well, you got off track there, but right now, if I go in, I've got chest pains, I'm probably gonna, best case scenario, walk out of that primary care doc's office with maybe a prescription or maybe a referral to see you.
Exactly,
I'm
right?
probably not going to have this conversation. I'm certainly not going to get the CT scan there, right? I mean, that's not going to happen. So, okay, this is good to know as I try to help fix the American healthcare system. This is amazing.
I'm telling you, it's easy, right? Fix high blood pressure. Don't use tobacco.
Yeah.
Massive benefits. Diabetes and pre-diabetes, right? Big factor, right? And what's interesting is, if you look at smoking cessation, which we've done a great job over the last 30 years to get people to quit smoking, right?
Right.
You see the curve go down like this.
Yep.
You know what happened just to mirror exactly that curve? As smoking went down like this,
Obesity.
weight went up
Yeah,
like that.
I believe it.
Right? That's what happens when you quit smoking.
Yeah.
Right? It's an appetite.
Yeah.
You replace one appetite with another appetite, right? And now we're both grayer. That's going to happen, but we're also a lot fluffier.
Yeah.
Right.
100%. 100%.
Yeah. I mean, hence the whole Ozempic and Wegovy and Mounjaro and Zepbound and all of those things. Yes, it's great. They're amazing drugs, by the way. But it's kind of pathetic that 70% of us are either overweight or obese, that 70% of us adults are eligible for these drugs.
I know. It's such a
Yeah.
shame.
But so diabetes, prediabetes, and then the last big thing, of course, is cholesterol.
Yeah.
So 100% of us who have plaque, we talk about tobacco, we talk about diabetes, prediabetes, talk about high blood pressure, and there's other factors too, but I'm talking about the big four modifiable drivers. 100% of people who have plaque have a cholesterol disorder,
Wow.
right?
Wow.
It could be high. Obviously, you can understand that can cause plaque, but do not feel comfortable or reassured that your cholesterol is average or below average. I can show you people all day long who have average and below average cholesterols, taking no drugs, who have significant plaque.
Right.
I like to say, look under the hood. So some people, what they don't know is they may think they have Teflon lined vessels and they have Velcro lined vessels. Now, again, things that give you Velcro: tobacco, diabetes, prediabetes, smoking, right? But if that cholesterol is getting into the blood vessel, then you have a cholesterol disorder, and that gets more complicated. There's ApoB and Lp(a) and LDLs and HDLs, and it gets way, way crazy, which, again, another certificate, board certified in lipidology for 20 years now. Incredibly enlightening. I mean, that is a major critical tool that we're always going to get back to, because that it is the ultimate fertilizer to plaque.
All right. So if you're talking about, I want to broach can be a controversial subject, and you're especially, it's a perfect question for you because you're a preventive cardiologist. Statins. What do you?
Yeah. So I will say,
Yeah.
and I get in discussion all the time,
Yep.
right? So here's what I'm going to say. We now in 2025 have a variety of different tools to lower bad cholesterol. Whether you think of it as LDL, which most people think of that, actually the best way of measuring all the bad cholesterol, which we do all the time, is something called apolipoprotein B.
Mhm.
That's ApoB. So if someone is using ApoB to look at your lipids, your lipid profile, God bless them, they're ahead of the pack. Okay.
Right.
Another tool that everybody should get once in their life, as we talk about measuring cholesterol, is something called lipoprotein little a.
Mhm.
So it's big L, small p, little a in parentheses, LP little a. It's a really, really nasty form of cholesterol. 80% of us will be normal. It is 100% genetically determined. So everybody should get it once in their life.
Okay.
80% will find out they're fine. Eat right, exercise, don't start smoking. It's great. You don't have it. LP little a does not show up on a standard lipid profile. It is completely invisible. You have to order that test.
Okay.
And if it is high, we do have tools that lower it 25 to 30% modestly, but we're right on the verge of having access to tools that have been in development for the last 6 years now that will lower it by 85 to almost 100%.
Wow.
So we're right. The first of these trials looking at these drugs that lower LP little a specifically will be reporting out within the next 6 months, in 2026. So
Wow.
if those trials are successful and the drugs are really, really effective, they appear to be very, very well tolerated. If that's successful, we will now have an entirely new, novel tool in our preventative toolbox. But even getting back to what we can treat now, statins we've had for 40 years. They're safe in most all people. They're well tolerated in most all people. They have proven themselves to be both safe and effective. The side effects are generally annoying, right? Muscle aches, joint aches. With the newer statins, we rarely see that. But if you get it, we know what's causing it. You drop the dose, you switch them. We now have a multitude in 2025, which is not the case 20 years ago, a multitude of proven, not just drugs that lower cholesterol with different mechanisms that are not statins, but also drugs that lower cholesterol and have been shown not just to lower cholesterol, which is a surrogate, but actually shown that these drugs prevent strokes and heart attacks and plaque and stop and reverse plaque.
Wow.
So we have a very large toolbox. Statins, the advantage, they're cheap. We've been using them for 40 years. More studies have been done. More science has been done with statins than any other medicine in the history of humanity, period, bar none, right?
Did not know.
So again, not perfect for everybody,
Yeah.
but for most people, they're really cheap, they're really effective, and they're great. So usually they're a foundational drug. We can talk about that. However, if you've had problems, and many people have, or side effects, or frankly, if you're just worried about it, right? I just won't do it, just on principle. I got a really big toolbox of drugs that are not only lower cholesterol, but also have been proven both safe and effective that are very, very well tolerated. Now, the downside is some of these drugs are still under patent,
Yeah.
so they're more expensive.
Yeah.
So more hoops to jump through and all that. But they're all great drugs. But so I think statins are a tool. Sometimes you need a flathead, sometimes you need a Phillips head, a wrench,
Yeah.
whatever. They're a tool, not bad, right? I mean, just they are. And if that tool doesn't work for you and you're a flathead and we need a Phillips, no problem. Get out of a Phillips. It's not a big deal.
Yeah. And I guess that just becomes kind of like a math game, right? It's like, especially if you come in, if I come see you and you go, Jason, you're fine, but based on your genetic profile, there is a very strong indicator that once you get 55, 60, you are going to see high cholesterol. So I'm going to tell you, here's a way to make sure you never get it is by potentially taking a preventive statin, essentially is what you're doing.
Absolutely.
And
Yeah. So I'll tell you, this is just today. We had 2 guys come in last week for their scans. Okay. And one is the dad, the other's the son. The dad is literally 30 years older than the son. So the dad has had bypass surgery, right?
Yeah.
And he had high cholesterol. We scanned the son, who's 30 years junior, right? His cholesterol, sky high. He was one of our 1%.
Wow.
He had no plaque whatsoever.
Wow.
So the beautiful thing is I can have a discussion with him saying, I got 2 options. Plaque is a slow glacial process, right? It is not communicable disease. It's not trauma, right? You got to sit and marinate at those cholesterol levels for a long time. Dad did. So 30 years down the road, that's probably what's going to happen to you.
Yeah.
If we don't treat the cholesterol. Now, short term, measured over a few years, 2 options. 1, watchful waiting, because he's not going to go from 0 to needing bypass in the next few years. Is it not going to happen? He may go from 0 to not 0. Again, no symptoms, no chest pain, I feel fine. But we can measure and track that using CT and quantitative AI, right?
Yeah.
So option 1, watchful waiting. You're fine. Nothing's going to happen the next few years. Option 2 is more proactive. Here's what happened to dad. Here's why it's happened. Your cholesterol genetically is too high. As I like to say, important that we fix the blame, not the problem. It was dad's fault.
Yep.
And his dad before him. So option 2, proactive. Yeah. I mean, I got lots of drugs. Statins could be part of that or not, whatever. But I got lots of drugs that in 2 to 4 weeks, I can drop that number by 50, 70%.
Wow.
And if you want to be proactive, make sure you never do start forming plaque. That's perfectly fine too. But that poor guy's cholesterol, eats right, exercises, doesn't smoke, no bad habits, normal blood pressure, blah, 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 no diabetes, prediabetes. It's genetic.
Yeah.
Right. And so we can do something about that genetically high cholesterol, but you're going to have to take some drugs.
Yeah.
Sorry, because it's hair color.
Yeah.
If you want to be blonde, you're not blonde. It's going to be at a bottom. Right.
Yeah.
On the other hand, if you want to defer that for a few more years, more data, more science, more tools, more drugs, more approaches come out 3 years ago, perfectly fine as well. So that's the beautiful thing about the certainty of this tool to detect plaque, to quantify plaque, and to track plaque, because it allows us to make these great decisions. This is shared decision making where we can say, yeah, no, I want to be proactive and get me on the drugs. No worries, that'll work. Or let's kick the can a little bit down the road. I do not have measurable plaque. I'm in the 1% already. And let's see what things look like in a few years. Either way, it's fine.
Yeah.
It's beautiful because we have the absolute certainty, right? Zeros and ones, I like to say. It's binary nowadays.
I love that.
You can see that with stress tests and EKGs and even heart caths, right? You can have a normal heart cath and have a heart attack the next week.
So what are some of the, like someone who is, they've listened to this and they're like, okay, I want to dial in to my cardiovascular health. What are some non-negotiables with regard to exercise, nutrition, environment? Just you as their cardiologist, you say, okay, look, I'm here to prevent you from having a heart attack. I'm not here to treat you after you've had I mean, you probably do, but I'm
Sure.
you know, the point of it. What do you tell people? These are the non-negotiables. You don't smoke, and then you don't.
Yeah. So no tobacco, regular exercise. Now you can get in the minutia, right?
Mhm.
Is it high intensity? Is it whatever? I'm going to tell people, particularly if you're not regular exercising, baby steps. It's okay,
Yep.
right? Just walking. Walking is phenomenal, right?
100%.
Particularly if you're doing nothing. If you're more sophisticated, you're already into exercise, whatever. I think again, the most important thing is move, get your heart rate up, get hot, and sweaty.
Yep.
The differences between those kind of exercises are modest. The biggest thing is move, get your body, get
Mhm.
hot and sweaty, get your heart rate up, et cetera. However, if you do want to get in the nuances, I think high intensity is great and efficient, and I think that's phenomenal. Um, I think it probably should be a combination of some aerobics,
Yep.
but also some strength training, right? Because muscle is a great thing to have for lots of reasons. In fact, on the diabetes, pre-diabetes, of which about 25-30% of us are pre-diabetic, another 12% or so are diabetic. Muscle is responsible for 80% of your glucose disposal.
Yep.
So if you want to prevent diabetes, it's muscle. And by the way, where's most of your muscle? It's in the legs. It's the leg
Don't skip
workout.
leg day.
I mean, we all want the guns, right? I get
Yep.
it, right? But it's the legs,
Yep.
right? So
Yep.
get from walking to whatever. So and then on diet, the best data, and that gets into, as you know, we've got low fat, high carb, low carb, high fat, plant-based, Estelin.
Right.
I was just talking to another cardiologist buddy of mine, who's a big plant vegan guy, which is all great. I will say the diet that everybody would agree on that has the best data for not just reduction in heart disease, but also weight loss, diabetes, cancer, and all-cause mortality is the simple, straightforward Mediterranean diet.
Yep.
Right? So we can all agree on that.
Well,
Alcohol, I will say, I love my red wine. However, I will say that the one thing that everybody in diet agrees upon, whether you're Pritikin, extremely low fat, to keto and carnivore, is alcohol is just never healthy.
yeah.
To be
Just,
honest, right?
yeah.
So that's the one thing in the diet world that everybody agrees on. If you want to lose weight, you got to get rid of the alcohol.
Yeah.
By the way,
Yeah.
unfortunately, as much as I hate to say that to my patients, but
Or if you're just like me and you're really vain and you want to slow down your aging, you want to look as good as possible, don't drink as much.
all of those things. Yeah, exactly.
Yeah.
And I will say that reminds me of something about smoking that I do remind people. Smoking is great for one thing.
What's that?
One very, very doable thing. If you want to be a nice, young, thin corpse, smoking's great for you.
What a sell. What a sell. So I got to ask, because how old did you say you are, Doc?
So I'm now, I'll be 62 here shortly.
Okay. You're lean. It's obvious. Your skin looks healthy. You're lean. So what do you do? What do you mind sharing your regimen?
Yeah. So, I really do try to walk the walk.
Yep.
I'm going to admit to you, I like junk food like everybody, right? It's yummy, right? It's designed to be yummy. That's why there's a massive industry. And I tell people, I don't care what you do once in a while. I care what you do every single day. And that's both diet and exercise. So I try to do a Mediterranean style diet. It's easy, sustainable, right? I think some of these diets, particularly the extreme diets, can be very difficult to stick with over any kind of long period of time, whether it's keto or completely plant-based or vegan. Now, if, I think there's better data on the plant-based, to be honest, than the keto. I'm still worried about that. We do know that some of the people in the keto, their LDLs, their cholesterols, their ApoB can go really high. Still worried about that. They say, well, I don't have insulin resistance. My walls are, they're basically saying they're more like Teflon than Velcro, blah, blah, blah. It's all good. I'm going to say, let's see what the science shows on that. I think the plant-based diets are great. Doesn't mean that you'll necessarily lose weight, because there's lots of overweight vegans out there as well. And there are challenges, particularly in getting some certain vitamins, in particular if you're very strict, and protein as well. As always, moderational things. But I think the Mediterranean diet works for the vast majority of people. Is, again, easy, proven, sustainable. So that's usually the diet that I usually discuss with my patients as far as that goes. So every day, or at least most days of the week, do at least 30 minutes of exercise of some sort, get your heart rate up, get hot and sweaty. And I tell people, when they say, what kind of exercise? I tell, find out something that you can do every day that you least attest.
Yeah. Yeah.
Right? Because some people
Smart.
do it. And I'm going to tell you, I hate exercise but I really love to have exercised.
Oh, yeah. I mean, I'm
On
telling
the other side of it, yeah, I'm glad you did that. But boy, and I wake up in the morning going, uh,
you. Yeah. Yeah.
I'm gonna tell you, some people like, I can't wait. I'm gonna tell you, I'm on the, oh boy.
Yeah.
But on the other side of like, man, I'm glad I did that.
Well, and,
Right.
and you just feel so, and the thing is too, that I try to tell people, Doc, is that like when I'm traveling, if I do a 20-minute hit cardio exercise in my room, if I,
Sure.
and people say, well, I don't have time to do that. No, you give me
You
2
need
minutes of
no
burpees.
equipment.
You do 2 minutes of
No
burpees
equipment.
straight, and I'll tell you,
Yeah.
you feel something.
Absolutely. No equipment to minimal equipment, right? I mean, that will, and that's why I say whatever you can do, fit in your lifestyle that you can do pretty much most every day of the week. Again, that's the most important thing, right? All the rest is really kind of in the weeds as far as I'm concerned. Just move, right?
100%.
It's Newton's third law,
Yeah.
right?
Yeah.
Things in motion stay in motion, things at rest stay at rest.
That's
So
100% right.
just stay in motion.
Well, Doc, this has been a blast. I am so glad we connected. Now, what have we not discussed that we need to talk about? Have we covered?
So you talk about the big four modifiable factors.
Yep.
Okay. Here's non-modifiable.
Okay.
And to get back to that question, okay, I'm 40, or maybe you're younger, but maybe I got some really worrisome side effects or worrisome risk factors. Remember,
Mhm.
risk factors are not the disease. They are things that could give you the disease, right? What we're going to do with cardiac CT and AI, Clear Cardio, is we're going to tell you have disease, not have disease. Zeros and ones, right? So I've seen a lot of people with a lot of risk factors who don't have disease. And then I've seen people who have minimal risk factors that have a lot. So risk factors are important, but at the same time, they are risk factors. They do not mean you have disease or don't have disease. So we talk about the big four modifiable. Make sure everybody gets their LP(a) checked, because again, lots of it out there. You don't know it. If you have a standard lipid profile, it doesn't show up. Make sure you get LP(a) checked. If you really want to do the lipids right, get ApoB checked. Some of my colleagues, even the World Lipidology, to look sophisticated, will get particle numbers and NMR spectroscopy and particle size and number. Yeah, we showed ApoB is cheaper, easier, better. It's one test.
Yeah.
It just that assumes all those things. We used to do that. We don't do it anymore. We learned. But family history, right? Really, really important, right? Early heart disease. That's literally defined as men having heart disease, your ancestors, right? Younger than 55 or women below 65. That is premature heart disease. If that occurs, then, you might want to get the machine before 40, right? But certainly after 40, if you have a family history, let's just understand what's happening, right? Eat right, exercise, do all the right stuff. But again, I can't change your DNA. We're working on that. But I think family history is very, very important for heart disease, for strokes, also peripheral arterial disease, circulation disease in the legs. And then also too, some things that just aren't fixable are they're rare, but cholesterol disorders, right? LP(a) is one of those. Familial hypercholesterolemia, that you can feel absolutely perfect, have no symptoms, I'm feeling great, and yet have very high cholesterol. So make sure everybody should have their cholesterol checked. I'm talking about adults, from every 5 years from 20 onward, or unless, we have other risk factors pop up in the meantime. Because again, you feel fine. And also the same thing with blood pressure. Make sure it's checked at least yearly in adults. Because again, from the age of 40, the lifetime risk of developing high blood pressure is 90%.
Yeah.
So I think that, and then another thing that is sort of under the radar, but there's been a lot of work on this over the last 10 or 15 years, are inflammatory conditions. Lupus, rheumatoid arthritis, HIV is an example, another one, and many, many others that are basically autoimmune, or again, in HIV cases, situations are infectious. But all of these create chronic inflammation, as does being overweight, by the way. And that chronic inflammation can literally change your vessels, again, from Teflon into Velcro. So if you have one of those autoimmune diseases, of which there's many, there was a beautiful paper published in the last couple of years that listed 19 of these diseases. So lupus, psoriatic arthritis, psoriasis, rheumatoid arthritis, and many, many others, that all of which substantially increase your risk of cardiovascular events outside of the typical diet, exercise, cholesterol, blood pressure, family history, et cetera. So I think those are very important risk enhancers as well. Kidney disease, another major risk in cancer as well. So there's a lot, but hopefully if you do get referred to a cardiologist, they'll say, you need cardiac CT and AI. Forget the stuff we used to do.
Right.
That's all in the museum now. Our stress test machines, our heart caths, suites, they're all, in the museums. They're interesting. And that's not to say that there are certain people that may benefit from stents. By the way, stents are only for symptoms.
Yeah.
They do not make you live longer. They don't prevent heart attacks. They're just to improve blood flow,
Yeah.
right? Bypass surgery largely is just to improve symptoms, okay, with some very rare exceptions. So if you visit the cardiologist and they say, oh, we'll start with an EKG and then we'll do a stress test, and maybe then a nuclear stress test, and maybe a cath, we're not sure. All I can tell you is do your research.
Yeah.
Okay? I'm not going to say run,
Yeah.
but I'll just say do your research.
Yeah, well, it's smart, and I mean, you've enlightened me today on that in that regard, because we always hear about the again, going back to the economics of healthcare, you hear about the over-testing and the unnecessary testing, and it's not that it's, in this case, a lot of times, probably depending on how the cardiologist was trained or whatever,
Sure.
they think they're doing the right thing. There's just an alternative that more people that needs to get out there. That sounds like
Again, 600 preventive cardiologists, 33,000 cardiologists out there. So my ultimate goal, and Jason, I'm gonna as we wrap up here, here's my every discussion, every talk should end with a challenge. I'm going to give you my challenge, okay? And I'm going to lean in hard on you.
Right.
My ultimate goal is to eradicate heart disease. Okay. When we've done that, I'll be successful. Okay. We're going to first of all do it by getting rid of the interventional cardiologists and surgeons. God bless them, but they're smart people. They'll find other stuff to do, or maybe they'll just become preventive cardiologists as well. Okay. Ultimately, though, and here's where we're going to lean into, Jason. And thank you for having me on, so we can talk about preventive cardiology, the state of the art, both in diagnosis. We didn't so much talk about therapeutics, but that's a whole another discussion. But here's where we're going to lean into you and everybody listening. Is ultimately, I want you and everybody listening to this today to put me out of business. Okay. Then I will know my profession and my passion my mission has been complete. Okay. Please put me out of business.
Deal.
So
I'm trying one individual at a time.
I appreciate it. I appreciate it.
I don't want to give you any business. Hey, Doc, how can people keep up with you and find out about what else you're doing?
So a couple things. Visit our website if you want more information. We've got lots of cool videos and stuff on cardiac CT and AI. So it's Clear Cardio, CLEAR, Cardio, CARDIO, clearcardio.com, real simple. Or we got lots of videos, podcasts on prevention, all about these topics we talked about in a lot more detail even on our YouTube channel. So Clear Cardio on YouTube. And our podcast series is called The Power of Prevention. Lots of cool individuals we interview that kind of tell their stories, and lots of cool stuff there as well. So YouTube, Clear Cardio, or just clearcardio.com. And we're also on LinkedIn and all the usual social medias as well.
Well, it has been a wonderful conversation, Dr. Osborne. I really appreciate you making the time, and have a wonderful holiday season. And thanks for joining us. I really appreciate it.
Absolutely. It really was a pleasure and an honor. And thank you again for letting me proselytize about prevention on your podcast. It was fantastic.
You're welcome back anytime.
The content provided in this podcast, The Healthy CEO, is for informational and educational purposes only and is not intended as a substitute for professional medical advice, diagnosis, or treatment. Always seek the advice of your physician or other qualified health provider with any questions you may have regarding a medical condition. The opinions expressed by our hosts and guests are their own and do not necessarily reflect the views of the Healthy CEO. Any information provided by our hosts or guests, including any physicians who may appear on the podcast, is solely for informational purposes and does not create any doctor-patient relationship. Listeners are advised to consult with their healthcare providers before making any changes to their health routines. The Healthy CEO and its affiliates assume no responsibility or liability for any consequence resulting directly or indirectly from any action or inaction you take based on the information provided in this podcast.